This is Focus on Your Health on the KJAZ Radio Network. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and this week I'm speaking with Dr. Thien Ngo. He's the medical director of KRMC's Acute Rehabilitation Center. Dr. Thien Ngo, welcome back.
Hey, thanks for having me, TG.
Yeah, I'm glad you're here. You are the medical director of KRMC's Acute Rehabilitation Center. You are a physiatrist. Today we're going to talk about nerve and muscle disorders, correct?
That's correct, yeah.
It may be instructive to begin with a simple definition of physiatry. What do you do?
Mainly, quote unquote, I consider myself to be, every time I talk to a patient, consider to be a functional doctor. We do a little bit of physical medicine, dealing with musculoskeletal pain, any nerve pain, and the rehab part is mainly for people who have severe disability coming from out injury. I'm talking about like brain injury, stroke, spinal cord, and amputation. So those are some of the typical cases that I dealt with in my patient population.
Let's talk a little bit about the history of physical medicine and rehabilitation, or PM&R.
Sure. Originally, as you know, we all know, most medicine have the streamline of either internal medicine or surgery, and you have subspecialty branching off from that two main stream. Well, PM&R may spin off from internal medicine. Start out during World War II, after all our veterans coming back with their leg injured, been amputated, spinal cord injury, brain injury. So who's going to take care of them in the long run? So initially they are dedicated to mostly internists or internal medicine doctor taking care of them, and then they branch up into their own specialized medicine field. So you initially have two different branches, and they combine to one society to form the name PM&R, Physical Medicine Rehab. And we still very, I think we started in the early, started in 1928. I think that's from what I have researched up. And until now, we have about roughly 70 to 80 residency program in the United States. So it's fairly a specialized field for medicine, but it's getting more popular. I know more and more people are interested in going to this specialty.
So you say it's this multidisciplinary field.
Mm-hmm.
And can you talk a little bit about the scope of the practice, the different things you have to tackle?
The scope of the practice is it's very nice. We aim to restore and enhance the functional ability and quality of life of those with physical impairment and disability. And that's pretty much in translation, we pretty much trying to take care of people who have a functional decline. Whether it is, do they need a new prosthetic leg? Do they need a wheelchair evaluation? Do they need more therapy? I'm talking about both in cognition, how they gonna put on their clothes, dress themselves, comb their hair, or versus standing and walking, or versus a paraplegic who want to participate in a basketball tournament. Offers a wheelchair basketball tournament. So things like that. So that's what we're trying to help, and we're trying to optimize the function of people with injury to the muscle, the bone, tissue, and the nervous system to the best that we can.
So when you're talking about someone who has, for example, a missing limb, you're talking about a lot of things that you can observe that are easy to observe, but then you're also dealing with a lot of what's going on the inside, nerves.
Oh
and
yeah,
muscles.
So let's say if one unfortunate to have a limb amputated either below the knee, above the knee, due to either infection, diabetes. That's some of the common case I've seen in our area. Then what's the next thing? Obviously after the amputation, the patient likely going to have phantom pain. That means the foot is gone, but they say, I still have toes pain.
Wow.
And when I do consult examining them, I ask them, let's say they have the right foot amputated, and I ask, do you have right foot pain? And they look at me like, are you crazy? Have you seen it's missing? Is this kind of some kind of joke? No, reality is, our brain is still wired to have that sensation. Wow. So, you have to use medication, and after that you have to observe the wound to make sure it's well healing, and when it's the appropriate time to take out the staple, the suture that the patient has, any kind of infection, make sure the stomach is well healing. And then after that, you can see the limb work in a close kinetic chain, and now what happened, you're missing part of it, the muscle tendon is going to contract, and you have either knee flexion contracture or hip flexion contracture. That means everything just pulling up, cause severe pain and discomfort. And on top of that, you think the patient mentality say, I used to walk with two legs, now I only have one leg. It can be depression, because they're losing something. They're losing part of their body.
Yeah.
And so that social psychological aspect play into it. Now they can't walk around for a whole lot. They're in bed, so they're gonna have blood clot from all the pre-morbid condition. And with that, being in bed for too long, decreased lung function, the heart change, the bowel and bladder become more stable, more static. They can have constipation. They can have bladder infection. So this has come up some of the expected common condition or complexity you have to deal with after the leg's amputated.
Right.
And so we work closely with them to either, number one is with their mentality, with their function, with their strength, to make sure they're able to do all this in a day with a therapist. So I have PT and OT work with them, and including myself, I check up on them daily. And once the pain improve, they're doing well. So a lot of time I joke with my staff, I'm here just to do three things. Poop, pee, and pain. That's the question every day I ask the patient, are you doing well? And once I'm doing great. I'm doing great with therapy, and then I let them be. I let them continue to work with therapy. And once they go home, and the stump is healing or the wound is healing, then we have to look in for a prosthetic leg, and we have to look at what kind of level are they going to go back playing golf. I have some gentlemen who still do parachuting with a. Wow. I'm talking about when I work at I was training at the VA. So, but that's, you can see the extreme case versus people who need to get in and out of the house, in and out of the bed just for transfer. Right. Yeah. People who going back to work. So that kind of whole process, getting the patient back to their previous level of function, is what I try to do.
Right. This is something not too long ago I spoke with your colleague Dr. Sarah Knievel about pain and mobility, and we were saying it hurts, so I don't get up and move. Yeah. But I don't get up and move, so it hurts more. And clearly, this thing gets out of control, right? You start to atrophy, and
it's a vicious cycle. Yeah. So a lot of time, anxiety. Dr. Knievel is the specialist. She knows way much more than I do on this area. But typically the anxiety, depression, and the pain always go hand in hand. And it's a vicious cycle that spiral downward your mentality, your quality of life, and I think that's what in some way, as our physician and mainly the specialist is Dr. Knievel, she tried to help you with this.
Yeah. And so very often, is there a counseling aspect of this?
Yeah, definitely. Yeah. Mental health play a very important part. Yeah. How to recognize a problem. A lot of time I refer my patient for coping strategy, right, and ways to deal with the problem. A lot of time my advice to them direct is that I'm not able to take away your pain completely, but I can help you to cope with it or make you feel in control of your pain. Of how you're able to tolerate, able to become functional day to day.
Right. Yeah. A moment ago you mentioned phantom pain. It's such an interesting phenomenon. How long does that usually go on?
It varies from person to person, and it depends on, some people have it, some people don't. But the majority, I would say, around the patient I've seen, 60% or around 60, a little bit more than 50, have it. About a patient I do consult when I ask them, and typically they could last anywhere up to a year or two. Wow. But most people tend to have improvement between 6 months to 1 year with proper treatment, and therapy and close care with a doctor or physician who knows work with phantom pain.
What are the strategies for rehabilitating and getting that pain to stop? I imagine medication is some aspect of it, right? Or not necessarily?
Yeah, medication is definitely some aspect. According to research out there, there's a variety of medication. With the whole phantom pain, we typically use the first GABA class, which is Neurontin. We titrate it up. This is used for neuropathic pain. And if that failed, then we always go to its cousin, which is Lyrica, and then some component of TCA. Obviously, there's different medication out there. It depends on the person. But education is the first key point. You have to explain to the patient what is going on and why they feel what they feel, and explain so they have an understanding of their condition. And after that, desensitization. That's been asking the therapy to do massage, stretching, help them to feel, don't touch it, and let's touch it, and this is how it's gonna feel, and then basically desensitize them to all the abnormal sensation of paresthesia at the thumb. And on top of that, when you have the amputation, the component of muscle spasm and muscle pulling is also play into it too. If you can imagine, every muscle have the insertion, the origin, and you cut a part of it. Now you just change the distance between the insertion and the origin, and then the muscle, and then the insertion. Now you just change that length, and so the muscle tend to pull, contract, and you have to work with that component too. And then you have the nociceptive pain, which is the piercing. Typically, I would simplify as a piercing, sharping, stabbing pain, and that can also play a role working with the opioids, narcotics, for a short term to help to relieve the pain in the three aspects from medication wise. I just want to mention that I have nothing to disclose with this talk. It's purely for the community and for KJS. I have no financial tie with any of the medication I mentioned in this program.
So Dr. No, will you take us to the break in Vietnamese?
Sure. Chúng tôi xin nghỉ giải lao dài Focus on Your Health. Chúng tôi sẽ trở lại chương trình trong vài giây. Đây là KJS, hệ thống đài truyền thanh.
Beautiful. Well done. Welcome back to Focus on Your Health, here on the KJazz Radio Network. This week my guest is Dr. Thien Ngo. He's a physiatrist and the medical director of KRMC's Acute Rehabilitation Center. A moment ago when we were getting ready to start this interview, one of your technicians knocked on the door and he said, "Sorry to interrupt, but I'm here. I've got this patient. She's in pain. She's had 7 surgeries or something like that, right?"
Yeah.
And so, of course, we'll respect patient privacy, but do you see that sort of thing often with a patient with multiple surgeries?
Oh, yeah, very, very common. I've seen people who have, I think my record says 7 back surgeries with no significant improvement, and they come here because the referring physician want to know an answer of exactly what's wrong, using the EMG nerve conduction study test to confirm. And the thought, my routine flow with most of the patient is that, number one, I go and I explain to them what I'm doing, and explain to them that the nerve conduction study, or NCS, and EMG electromyography is only an extension of my physical examination. 60% is from taking a thorough history, either in writing or in asking questions, and then examination, a full neurological, like testing for the sensory, the reflex, and then the strength. And then after that, after I form my clinical differential diagnosis, I use the nerve conduction EMG to help me tailor that or confirm the diagnosis. And then the remaining 20, so you have 80% EMG, 20 clinical history and physical is 60, and then the remaining 20% is from either X-ray, MRI, CT myelogram, ultrasound, different imaging techniques. Yeah.
I'm just thinking 7 surgeries, and then the patient comes to you, and it's as though you're the last resort. Right?
Oh no. So a lot of time you go to different physician, and some you do well with, some you don't, and I think they just want a additional input, an additional perspective, because when people in pain, sometimes the problem is too severe, and they don't see the result from other physician, or right away, or there's is working on it, and anybody or up for a second opinion, third or fourth opinion. So typically they come to me to get an additional opinion to see what else I'm able to provide for.
Right.
And a lot of time, if they've seen about 7 or 8 other doctors, diagnosis has been made, and so I usually review those information, and put things together. And a lot of time, it's been documented, and you explain to the patient, it is what it is, or is something else we can do. And then if it is what it is, I think it will help with education. You talk more about what kind of condition they have, what are they going through, and what the expected outcome for different condition. And I think usually that set them into a better mindset of dealing with the problem.
Yeah. So let's talk about some of the other nerve and muscle disorders you see.
Sure.
One of the really common ones is carpal tunnel syndrome.
Mm-hmm.
In brief, what is it?
In brief, it's just the entrapment of the median nerve. If you look at our wrist on the palm side or the palmar aspect, you see above the wrist there's a tendon sheet called a flexor retinaculum.
I'm doing this right now. I'm holding up my hand so I can.
So you have the flexor digitorum profundus and you have flexor digitorum brevis. And on top of that, you have one thumb tendon muscle going out of it too. And between that is the median nerve. And you can see my whole point is a lot of structure and one nerve going right in between. And due to either repetitive activities, obesity, arthritis, which chronic condition you may have, it might affect this nerve and cause this nerve to be irritated, to be painful. And so a lot of time, either the primary doctor or orthopedic surgeon refer the patient to me to get an objective, quote-unquote, objective measurement from the nerve conduction study test to see, number one, is it mild, moderate, severe, right, so that they can make a decision or help them in making a decision to operate. And another thing is they want to rule out, is it not coming from the neck? If you have a radiculopathy, which is a nerve impingement on the neck, then you can also have the same sensation. So my role is, number one, is to evaluate, asking for history, do a thorough physical examination, and on top of that, I will do the nerve conduction study test and send a report back to either your family doctor. Do you need occupational therapist? Do you need injection? Do you need medication? Do you need carpal tunnel exercise? Do you need night splint? Or you need surgical release? So typically I'm trying to answer those questions for the management of carpal tunnel on my end.
You could have you mentioned an impinged muscle in the neck. Mm-hmm. Would you also have neck pain with that?
Yeah, typically so you have neck pain. You have neck pain radiating
carpal tunnel pain and neck pain all at the same time.
Yeah, some people have both, so it's a, I would say, double whammy, I guess. Yeah.
Now, when you describe that, I picture someone who has to sit at the computer for long hours, and of course, those are the people oftentimes who have carpal tunnel syndrome, right?
Typically, but it could affect anybody. If you can imagine a nursing mother who have 3 or 4 kids who have to carry her kid on the side, she have to bend her neck all the time. Exactly, and you can see she pretty much narrowed the neuroforamina, or the hole where the nerve exists, and so you can have numbness going down on that arm, on that particular side. On top of that, you have also degenerative joint disease from the herniated disc from the back, and the arthritis chronically, and you can have also a variety of condition, the neck, muscle spasm, myofascial pain, and facet arthropathy associating. So my role is just number one is to see if I can put things together to see which one affect you the most, and where do we go from there.
A moment ago, you said something that kind of jumped out at me, and you said you mentioned obesity in the context of carpal tunnel syndrome. Mm-hmm. I have never thought of the connection between these two.
Well, I mean, you can imagine the wrist in a small space, and then with the whole. This is one of the risk factor that might have caused more narrowing for the carpal tunnel.
Never thought of that.
Yeah, and then you can see the weight of the hand and the wrist, and then not only obesity but also diabetes, and then arthritis can also be some of the common players too.
Yeah. Tell me about peripheral neuropathy. What is that?
Number one is the nerve damage. In simplified term for myself, is a nerve damage in all your extremities. Okay, because if you can imagine, our nerve, they run in little axon, and the group of it, they form is either epineuron and then the endoneuron, and so you can. The basic analogy for me is a bunch of small wire cable running together in a group. So that's your nerve. On top of that nerve, that's called myelin sheath. And between the muscle, there's a little cut they call neuropathy, and that's how the body sends signal to tell your hand to move, to tell your body to do certain things. And you both have the sensory system and the motor. Simplify it, the sensory system is basically if you put your hand on a hot stove, the signal sent back to your brain. That's the sensory part. And now your brain tells you to pull your hand away from that stove, and that is the motor part. And a lot of times this process gets damaged through either from chemotherapy, diabetes, thyroid, renal cell damage, or toxic environment exposure can damage this nerve. So you have paresthesia because in the body there's 4 different sensations we typically feel. Number 1 is a proprioception, where you are in space. If you close your eye now, you can see I'm standing on the ground. And vibration, something vibrating at your bone joint. And after there's a light touch, and then the pain and temperature. They travel together to different track in the body, into the brain, a different spot. And that's under our skin. There's different layer, and this receptor locate at different place. And when you have nerve damage, a lot of time this mixed sensation can create for you to feel. Sometimes a light touch can feel as a hot burning sensation.
Really? Yeah.
The patient feel cold and numb all the time, versus they cannot feel where they are in space. Like most diabetic patients tell me, I feel like I'm walking on stones. Like
okay.
When they take a step, it's like closing their eyes and trying to find the ground. And that's how they feel. And so my role in this part is to do a screen to figure out, number 1, is it sensory or motor? Is it sensory with the axonal damage, or the nerve damage with the myelin sheath demyelinated, such as Guillain-Barré, or a different demyelinating process. Beside the peripheral neuropathy, I like to touch upon the testing, looking for the patient with both upper and lower motor neuron sign. What's mean? Is the damage coming from the brain and the spinal cord, or versus from peripheral nerve? Where is it at? And a lot of times can help give you to diagnosis like ALS or different pathology involving the upper motor neuron, and as well as see the difference in them.
What sorts of treatment plans can you come up with then for peripheral neuropathy?
The typical number 1 is I have to figure out if on my test it show 3 out of 4 limbs according to the diagnostic criteria it's been affected. Then my next thought is what caused it? Is it a thyroid problem? Is it a vitamin deficiency, like vitamin B12, or is it chronic, environmental exposure? What is it that caused the damage to the nerve? So that's the next step. After you figure out you can address that problem, is it a vitamin B12 deficiency from the lab test? Then you test for that. If it is come out to be a thyroid problem, undiagnosed thyroid problem, you treat for that. And then diabetes, majority % of the case I have is diabetic who came in chronic diabetes port control. So I recommend number 1 is therapy to desensitize, to do protective equipment like diabetic shoes to protect the skin, the cut. Because if you imagine, if you can't feel your legs, you have a cut, or you step on a thumbtack, you won't know for a few days.
Yeah.
And then become infected, become gangrene, and now become a vascular problem. Now it become amputation.
Right.
Some of my patients start out that way, from a small wound in the leg, and it take a long time to heal. With that being said, then you send the patient to the podiatrist, to the therapist, and you educate the patient, and you start him on medication, Neurontin, Lyrica, TCA, and on top of it you can use cream. There's different cream out there, but the one I use is, I have to think cost conservative for the patient, because we're in the underserved area. So I recommend typically things that Medicare and generically, the $4 Walmart list would help the patient, like capsaicin cream and things like that. And after that, you control your glucose. Make sure they stay in the stable range, or the optimal range with your primary care doctor.
That's Dr. Thien Ngo, Medical Director of KRMC's Acute Rehabilitation Center. Dr. Ngo, thanks so much for your time.
Oh, thank you, TG, for having me on the show. I appreciate it.
And that's the program. I'm TG LaFredo. Thank you for listening. And please join me again next Saturday at 11:30 a.m. for another edition of Focus on Your Health, right here on the KJazz Radio Network.